So after we talked about the option of surgery versus medical management and the component of medical management, we will move on to discuss section 5, which is surgery. Surgery, generally what we do most commonly is a procedure called hemilaminectomy, and this is usually best demonstrated by looking at the picture. So if you just put the word hemilaminectomy and dog in there, you will find a lot of surgical pictures trying to explain how it's done. But basically is, if you look at a vertebrae, this is the front end of the dog, and this is the back end of the dog. This is their bones that are kind of articulating two vertebrae together. So by removing that articulation, you're able to create a window like this and access the bottom of the spinal cord to retrieve the disc material. And that's how you can do a decompressive hemilaminectomy. The let me see. The timing of surgical decompression has been a controversial debate for decades. There have been many papers that are listed in table 4 that look into like how fast you have to do the surgery or how quickly you have to do the surgery and whatnot. This is kind of where we stand as of 2022 when this paper got published. We know the pathogenesis of disc herniation-induced spinal cord injury support that surgical decompression should be performed as early as possible for dogs that would sustain a severe neurologic deficits. However, taken as a whole, the current literature does not generally support the use of a specific timeline for urgent surgical decompression, even for dogs that are deep pain negative, that are paraplegic at the time of presentations. So what it basically translates, is historically we have been cutting, spinal cases at midnight, at 1 o'clock in the morning, 2 o'clock in the morning. More and more evidence is accumulated saying that may not really materially change much of the outcomes. And so people generally feel like, okay, if that is not medically necessary, it probably is better and safer to perform surgery when we are more awake and the staff is doing normal performing procedure in the normal work hours, right? Um, One thing to be mentioned is there is some evidence to say longer anesthesia duration may be associated with a poorer outcome, and that primarily came from this paper that got published in 2020. They found that associated between anesthesia duration and outcome in dog with surgically treated acute severe spinal cord injury caused by disc herniation. It's a retrospective study, but the findings primarily support that a negative association between increased duration and anesthesia and outcome of this group of dogs, which I think that is kind of a confirming of common sense, right? A shorter duration usually brings a better recovery for the patients. They have a less hemodynamic not instability, but hemodynamic challenges during the procedure and usually makes a better recovery overall. The other things that I also emphasize in this consensus statement is surgical treatment should not be declined simply because the dog has been paralyzed for an extended period of time. There have been several beliefs that has been proven wrong that, if the dog has been not able to walk for, let's say, 4 days and there's zero chance of recovery, the more kind of delayed surgery we do, the more we learn. Actually, there are dogs that, despite the duration of being not able to walk or not able to move their back leg, if you still give them a chance to do surgery, some of them can still still achieve a functional recovery. Then it gets to the more important part of section 6 of fenestration. So fenestration is the process like this. So once we get to the surgical site, we then can create a window on the outside ring, the gray color part, to scoop out any leftover of this material, the red part on the vertebrae or in the disc. And that's really helpful because you not only remove the residual disc herniation, that really help with lowering the recurrence rate. So the agreement after some studies that look into is fenestration of the herniated disc space at the time of surgery is usually recommended to minimize risk of recurrence at the site of a herniation. And a number I usually share with the clients is coming from here. We know most of the recurrence usually develop about one disc in front of it or one disc behind it. Let's say we today have a first and second lumbar vertebrae disc herniation. We did surgery on them. If they have herniation, it's usually like the last thoracic vertebrae to the first lumbar, or like L2, L3 that has a disc herniation. Different breeds have a little bit different reporting recurrence rate, but generally speaking, recurrence rate in this particular study, they mentioned that it was about 18% with a single site fenestration, but reduced to about 7.4% with a multiple site fenestration. So that's kind of where I operate at, is whenever I have a disc herniation, if the approach allow me to do multi-site fenestration, I would try to do so. Um, and this is also supported by like fenestration of adjacent disc, which is also where they usually like to herniate, should be considered. Then they talked about the adverse event approach and techniques of fenestrations. Usually they're not particularly challenging. There is some discussion about like, do you do it too high or do you too low? But since most of the site when we do thoracolumbar disc herniation is somewhere between like 12, 13, T12, T13, L1, L2, L3, those are usually the sites that are easily accessible to do the fenestration. Then one thing I probably have a few people ask me about before is the percutaneous laser disc ablation. So that is basically finding a needle sticking into the disc itself and have a laser shoot into that needle to kind of vaporize the disc material. The most recent primate paper is probably this study came out in 2016. They had about 303 dogs that underwent percutaneous laser disc ablation, for which a minimum of 3 years of follow-up information was available, for which recurrence was documented within 3 years after the procedures. Overall, they found about 20% dog had a episode suspect or confirmed to be a disc herniation undergoing the percutaneous laser disc ablations. Most of them are only back pain or remain able to walk, just somewhat wobbly. Only a small percentage of them had to be going to surgery. Overall, they conclude this is a fairly safe procedures to do and can be considered if you have a doctor that can do that. As of 2026, I know there are probably three, if not four places that have the machine to do this. One in Texas, one in Oklahoma, one in Pennsylvania, and I remember one more, but I can't exactly know the place. But since I work in the Pacific Northwest, those are places not that are technically available on the map, but takes a long time to be there. But if you have access to able to do that, it may not be a wrong choice to do so. Then we would go on to neuroprotective strategy and pain management of the surgery, which will be another topic for the next talk.